Hi, Dr. Albitar.
Hi, Darryl.
Thanks for taking time to talk with me today. We're going to talk about a critical topic for Black men and their families regarding genomic testing and cancer. Can you tell us what kind of doctor you are and where you work?
I am a pathologist in training as well as a molecular pathologist. I am the Chief Medical Officer of Genomic Testing Cooperative, as well as the CEO of Genomic Testing Cooperative. Genomic Testing Cooperative is a diagnostic company focused on doing molecular profiling of cancer and focus on cancer testing for the purpose of providing information for precision medicine.
So is genomic testing something that you would call a diagnostics, like the first thing a person does when they wonder whether or not they have cancer?
Actually, that's one use. Second use is that you already have the cancer, but you want to explore the specifics about that cancer and the driver abnormality and figure out what type of targeted therapy you can use. So you target the molecular abnormalities in your own personal cancer. And this is why it is precision medicine or personal medicine, and use drugs that target these abnormalities in the cancer.
So for Black men in the United States, there's enormous concern about accessing healthcare at all in the last few years, certainly, but throughout history, Black men and women have faced racism as they access healthcare, whether it be with an individual physician or a hospital. Genomic testing is a blood-based thing. Is that right? It's just a blood drawer and the blood goes to a laboratory and you figure things out?
It can be blood as well as it also look at the abnormalities in the tissue. So if you do biopsy or you get the tissue and you take it out, we look at the tissue, what the abnormalities in the cancer per se. And as a matter of fact, we do more testing for solid tumor on the tissue, in addition to the blood also for staging of the patient and for looking for some changes in the cancer. But the bulk of our testing is in the cancer itself and for the patient also. So the whole purpose is to profile the cancer and to profile the host, which is the patient immune system. So this way, we can put all this information together and determine what's the best therapy and management for that specific patient.
So one of the hallmarks of racism is that when you hear, like, we're going to do either a test or a procedure or offer a medication for a patient, and it will be the best treatment for them, in the back of most people's minds is that it's not all patients, it's for white patients that have, primarily been the audience for, the subjects for clinical trials, the tests for this. How do Black people in the United States, should they feel confident that genomic testing actually applies to them, is useful for them?
Very good question. My history, I worked in academic centers in MD Anderson Cancer Center for 13 years, and I moved and worked in more community-based practice. Unfortunately, most of the patients who are studied in academic center, exactly how you said it, they are white populations. So the science that comes out of it is a little bit biased toward this particular population. We know that we are different. We are the same, but still we are different. Our bodies and our genomic components can play a major role in fighting the cancer in developing cancers. And it is very important to look at the genetic backgrounds of the cancer itself, as well as for the host in specific ethnic as well as social economic populations. And unfortunately, most of the academic literatures does not address that. And I think it is time that we really focus on that, collect data and develop therapeutic approaches that really personalized by the meaning of precision medicine. You cannot have precision medicine. We hear a lot about precision medicine if you don't count for the ethnic backgrounds, for the social economic backgrounds, for all other potential variation we see between humans. We know for sure that two patients who have, let me say, prostate cancer, they, even if the cancer looks the same, and the staging is the same, but it's quite possible the outcome in one patient might be completely different from the outcome on the second patient, even if you treat the same therapy. And that's what's really important in precision medicine today. And this is what we are pushing for at this time. We need really to study, put all the picture together, whether it is ethnic, socioeconomics, and exposure through the lifetime of the person, the changes, what we call epigenomic changes throughout our life, they play a major role in how we fight cancer and how we deal with, how our body deals with cancer, and the therapy need to be adjusted accordingly.
So this, and allow me to cough for a second. So this, I mean, you hit on a parallel critical issue for Black men and women in the United States, is that in the environment that you were, born into, grew up in, experienced your early years, and have navigated to the closure of your life, is usually different than for the white man, white patients, and in a whole host of ways, from stress of having to face, critical contacts, throughout your life, police, fire, just understanding a relationship between a teacher in primary schools, having to have the talk with your kids, and things like that. But also the general environment. I mean, Black people are not all living in poverty, but many do, and many are exposed to lead paint as youth. Many are exposed to a diet that may not be as, wholesome or organic as may be available in whiter neighborhoods or economically less challenged neighborhoods. And again, worth saying again, that we're not talking about 100% of Black people in America, but I mean, it's a concern within the community to find out how the environment, the work environment, how the home environment, the emotional and stress-laden environment has contributed to health over their years. How does genomic testing understand that for Black people versus for white people?
Absolutely. Everything you said is absolutely, I agree with, and it is very relevant. So genomic testing is what we are doing at this time, is we are profiling, it's quite possible the driver abnormality in the cancer itself, they are slightly different. We are collecting data, so at this time, we know very little because, as we started saying, that there is very little study on this. So that's one thing. The second thing is we know today that the immune system in a person plays a huge, important role in fighting the cancer, in the treatment, and the success of the treatment of cancer. Immunotherapy currently is a huge part of the therapy of cancer. And we need to understand how the immune system in this person versus that person, and we need to collect that data. We have very little information on that. So that's one thing. Second things, we know, especially in prostate cancer, that 10% of patients who have prostate cancer, they will have genomic abnormalities in genes that make them predisposed to having cancer. And it's quite possible that predisposition is very important, not only for screening and for detecting the cancer, but also for the therapy of the cancer. So if you have, let me say, mutation in BRCA1 or BRCA2 genes, which cause breast cancer in women, if you are a man, you're going to have higher incidence of prostate cancer. And the therapy might be also different because there are drugs that works even better if you can demonstrate that you have these abnormalities. In particular, we can talk about PARB inhibitors and so on. But it might have also implication on other members of the families. And this is where molecular profiling is very important, and molecular testing is very important. And all this information need to be put in front of the patient. And the clinician need to have all these information. And this is why we emphasize, in my medical opinion, every patient with cancer should have his cancer, every patient has the right to ask for to have his cancer completely molecularly profiled, and to understand the driver abnormality. And in my opinion, today, where also the science is evolving around it, is to look at the host, which is the patient itself, immune system, and profile the immune system, and have all these informations available for the patient and for his treating physician, so they can sit down, discuss it, and plan strategy for therapy. We are today's cancer in many situations is becoming like a chronic disease. We live with cancers and we survive it, and we deal with it the same way we are dealing with diabetes and cardiovascular diseases and other things. So all these are very important informations, and we need to make sure that whether you are Black or you are white, you are whatever your ethnic backgrounds, the entire population having access to these informations. And this is where the disparities in cancer is very serious problems, because we see it in our society, unfortunately. And this is, one of the richest countries in the world. We have these disparities. We need to do something about it.
Well, Dr. Albitar, thank you very much for this discussion. I think the takeaway probably is very simple. Every person, Black, white, male, female, transgender or not, whoever you are, genomic tests are as critical for understanding your health as just, showing up and having a stethoscope put against your chest. And, that the entry to this testing may be as simple as just a blood draw, may be a bit more complex with a biopsy, but the information you get would probably be life-saving. And at least if it reveals nothing, then you could get a better night's sleep knowing that you did the best you could to find out what's going on inside your body. So thank you very much, and hope to talk to you again.
Thank you.